And we're back with Jared Powell. I believe for round three, last time we brought you on, we were talking about shoulders. And I believe the first time we brought you on, we were talking about shoulders. So for round three, this is going to be not about shoulders. It's going to be this general or big topic of advice and reflections as a new grad physio and for new grad physios. For people that may have not listened to these prior two episodes, Jared, or aren't familiar with you, let's give just a brief intro on yourself and then we'll dive right in.
Thanks, Chris. It's really great to be back for number three. It's cool to reflect back on what we've talked about already, and hopefully we can go in a slightly different direction today. I'm sure I will invoke shoulders at some point though, so apologies in advance. I am a physio. As you can tell by my accent, I'm Australian, from Queensland in Australia. I'm a dad of two. I've got a beautiful wife, and I like, what do I do? So, my life's changing a bit. So I've just submitted my PhD, and that's been a near decade journey of blood, sweat, tears, and joy. That's been a big thing, and so I'm sort of starting the next chapter of my life where research is going to still play a part of my life, but it's going to be a much smaller facet of my life, thankfully, and I'm going to engage more in clinical practice again and getting out and starting teaching and running workshops, which I used to do a long time ago before research took up a lot more of my time. So that's coming to an end. And then personally, I love sport and exercise. I've recently developed an obsession with running, which is a little bit unusual for me. I've come from a real strength and lifting background, and I couldn't stand running. I did a lot of athletics as a kid, but sprinting, never anything over 200 meters. So now I'm enjoying the 5 and the 10K, which is interesting, which I'm sure will progress to the half and the marathon at some point, because that's what happens when you get old. You get slower, but you can run for longer. That's me. And I love, also have a big passion for rugby down here in Australia. It's rugby union. I just enjoy I've got a 4-year-old, and he's just started to do some really cool things. Like, he's just started skateboarding, started scootering. So we're at the skate park several times a week. So I'm just enjoying that. And then soccer starts for him next year, and little athletics and all these things, which I'm really looking forward to. So yeah, a bit of a rambling answer, but hopefully that gives you a snapshot into me as a person.
Well, congrats on being near the end with the PhD. And you said it's been almost a decade. When you started it, was that your expectation, just with balancing everything else that you are doing, or was that an unexpectedly long amount of time?
No, I started part-time, so I knew it was going to take, up to 8 years. I lie, it hasn't been a decade. It's been 6 years, but it feels like a decade. So I've done it, before the allotted time that I've had, but it does feel like it's been a long time. Like, since I started it, I've got married, I've had 2 children, I've moved houses multiple. It's amazing when you reflect back 6 years how much can change, and so I'm quite proud of the things that I've accomplished while doing a PhD at the same time. Actually, it's amazing what you can do when you allot your time somewhat productively.
Yeah, for sure. Well, I'm living with someone who just started their PhD. My girlfriend's just finished her first semester of a clinical psychology PhD. So I'm curious how she evolves over this 6 or so years, and then where my own kind of career growth will be, just with how long these things take and where we'll end up. So yeah, props to you for being near the end and that kind of transition of life. That's awesome.
Thanks, man.
So let's just discuss the paper to begin with, and then I want to dive into all these different topics. But within the past few months, I think it was October, out of JOSPT, you published a new paper, this editorial or this commentary with Chad Cook, Jeremy Lewis, and Karen McCreesh. And the title of the paper was "Dear Newly Graduated Physical Therapist, a direct message containing advice we wish we had received." I loved just the title and the content within it. And that's why I'm bringing you on. But as still a new grad, being 2.5 years out, I still love that y'all were able to provide this information, and it was valuable for myself. And I know it's going to be valuable for so many other physios and other rehab providers. But can you discuss how this kind of started? Is How did the four of you all decide to come together and write this piece?
So the genesis of the paper is very simple. So it's basically years and years and years of new graduates and students asking me questions about what would you have done if you were in my position, back when we graduated, back when the wheel was invented several millennia ago. And then so I started to compile a blog, as you do. And then as the blog started to take shape, I'm like, this could actually help much more people. And perhaps I should write this thing up and try and get it published. And then I didn't really want it to be from my perspective and my perspective alone. So I invited some people to collaborate. And who better to invite than Jeremy, Chad, and Karen, who are giants in the field, who have hundreds and hundreds of academic publications to their names, and without without trying to age them, they've got nearly 100 years of clinical practice experience to their names as well. So, that's said with all due respect. So yeah, their collaboration was absolutely amazing as well in terms of the insights that they had offered, and also to get people from, Karen's from Ireland, Chad's from the US, Jeremy's a New Zealand slash Australian slash living in England, so he's got a broad background, and then I'm an Australian, so limited to the West, but a lot of different backgrounds as well. So I invited them. They were happy to jump on and collaborate. And the points that I had, I originally had like 10 to 15 dot points, and then we whittled them down to 5 or 6. And they added some, and I took some out. And so it really was a collaborative effort in the end. And I'm very content and satisfied with the bits of advice that we offered in the end. And I truly do think that if I was given some of this advice 15 years ago now, when I graduated, it would have changed the first few years of my practice, which I found very challenging in retrospect. And I had a lot of moments of, although I didn't really know it at the time, there were moments that I really could have left the profession. Instead, I left the country, and perhaps we'll talk about that. But yeah, there were some really tense moments in the first few years, and actually still now, as I'm sure you'll all resonate with, there are difficulties that come along because that's the job. But yeah, I do feel happy with what we've written, and I do think it would have helped me 15 years ago, and hopefully it helps others at the moment.
Yeah, can we go back to 15 years ago, new grad Jared? What did things look like for you immediately after school? What did you see yourself doing as a new grad, or maybe years down the road? Where was your mindset on being a young clinician? And yeah, let's just kind of take it back.
So I did at university, I became obsessed with musculoskeletal physiotherapy. And that for me just felt like it was concordant with my logic, my sort of disposition towards science and analysis and critical thought, I guess, where I thought that I was a detective, and I was trying to find the source of somebody's symptoms, and I would apply, a battery of tests that would diagnose a pathology, and then I would have a corrective exercise or manual therapy technique that would fix that impairment, and lo and behold, they would get better. And that sometimes works, and I don't want to shit on that approach, pardon the pun, because all approaches are fairly similar in the end. So I came out, I worked in a private practice, I saw musculoskeletal injuries day in, day out, sometimes 70 patients a week for 2 years. As a new, I was 20, 23, 24 years old, and I was loving it at the time because I was exposed to this I guess industry of seeing people coming in with all variations of pain, low back, shoulder, ankle, stress fractures, and I was proficient in understanding what to do, and being a decently good practitioner. But I was starting to observe that outcomes were unpredictable in some respects. And I would, you know, I could apply the same intervention and the same exercise, and the outcomes would be unpredictable, which was starting to do my head in a little bit. So I had thoughts of going back and studying medicine, and I had dreams of becoming an orthopedic surgeon or a sports physician, more specifically, where these guys were held up in high regard here in Australia, where they were expert diagnosticians. And if a physio couldn't get somebody better, we would refer them. We had this one guy that we referred them to who was a sports doctor, and he, you know, would do these diagnostic blocks or these specific imaging techniques that would find the nociceptive source of somebody's pain. And you know, sometimes they would get better and often they wouldn't. So then we'd have to send them to somebody else and blah, 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 blah. So I started to think, you know, maybe this biomedicalism isn't exactly what it's all cracked up to be. So after 2 years, I fled the country, and I went to work in London for a couple of years, and I traveled all over Europe, and it was amazing. It was a fabulous experience. And while I was in the UK, I came across the work of Jeremy Lewis, which changed my life, actually. And I read a lot of his work on subacromial impingement and how he refuted that basically 15 years ago. And now we've got studies that have come out which have corroborated a lot of his theories and hypotheses many years ago. And I'm glad that I came across all of that. Yeah, I don't think I'd be where I am today without that.
When you traveled to London, you were a practicing clinician while you were in London, or you were just fully taking time away?
No, I still worked in the UK. And yeah, it was, yeah, but I didn't have it wasn't as much of a clinical burden as it was back home. In Australia, I really identified myself as a physio. Over there, I took a job to make some money so I could travel. But I sort of removed myself out of the pressure cooker of being in a really busy private practice.
Do you remember how you initially found out or heard of Jeremy?
Yeah, so I remember reading some of his stuff at university. He published a really good paper in 2010 or 2009, which was applying Jill Cook and Craig Purdam's continuum model of tendinopathy to rotator cuff tendinopathy. And I just thought that was fascinating because that was very different in the shoulder to what everyone else was doing, which was still shoulder impingement and rotator cuff tear and motor control exercise and corrective exercise. And he established a similar model to how we treat Achilles and patellar tendon pain in the shoulder. And I thought, this is so cool. I can get around this. This makes a lot of sense. And then so I sort of followed his work closely. And then I think in 2011, he published this real revolutionary narrative review on subacromial impingement syndrome, where he called it an illusion, basically, which then got me thinking, oh my God, you know, this is an entrenched diagnosis in musculoskeletal practice. How the hell can this be challenged? And what does this mean for everything else that we hold near and dear? You know, it just sort of made me think that perhaps, you know, this knowledge that we think that we have in physiotherapy is not as stable and as certain, which we'll talk about a bit later, I think, uncertainty, as we're led to believe it in university. So yeah, that was a real revolution for me in terms of questioning tightly held beliefs.
Yeah, since you brought it up, certainty and uncertainty, that was one of the main starting points within this piece. And there's kind of a variety of things or topics that you all touched on throughout this piece, but I think uncertainty is a major one. And this idea of learning to cope with uncertainty as a new clinician. Can you touch on what you all discussed within the piece and what the value of that is?
Yeah, so uncertainty is something that's I had never thought of in physiotherapy, musculoskeletal physiotherapy, until 5 years ago, maybe. I did think that that we could ultimately find a solution to somebody's pain. You know, perhaps with evolving imaging, perhaps with more experience, perhaps with better blood testing in the future, so on and so forth. You know, if you were to reduce somebody's complex experience down enough, you could find some sort of aberrant feature that was causing their pain. And this sort of, this is at the heart of, we might get a little bit philosophical here, but positivism and reductionism and finding, simple causes for somebody's complex experience. And if about 5 years ago or a little bit more, I started to really embrace complexity science as an approach to understanding pain and understanding biology, basically any complex phenomenon. Anything apart from physics basically is complex, and is at the mercy of a bunch of different variables. And when something is complex, and when I mean complex, I mean not complicated, I mean complex. So complex means it's unpredictable in terms of how that thing is going to respond in the future, or how it's going to behave in the future. And contemporary thinking suggests that pain is truly complex, and it's different from person to person, and it can change on a whim, and it can be entirely unpredictable. And so if we truly embrace complexity science as being this thing that is truly unpredictable, then that means that a lot of our interventions are going to be grounded in unpredictability and uncertainty and individual outcomes. Even if you apply an algorithm or the exact same treatment to every single person, we see in randomized controlled trials that outcomes are different based upon standardized treatment. And so we have to be okay with that. We have to be okay with that uncertain outcome. And Natalia Costa does a lot of really interesting work on uncertainty, and she's a researcher and PhD out of Brisbane. And she introduced to me this saying that uncertainty needn't prevent action. So even though a lot of the things that we do are embedded in uncertainty and are inherently unpredictable, we can still act. We can still try and help somebody, but we need to be able to think on our feet. We need to adjust our priors and our hypotheses. Okay, we tried this, it's not working, let's try something else. And we need to be okay with that trial and error approach to management. So even though something is uncertain, it doesn't mean we should just stand idly by and say, oh my God, I have no idea. We can still act and try and help. So I guess the whole point of the uncertainty, a bit of the paper, was to really reassure young clinicians that uncertainty is a part of our practice. It will be forever. Even in medicine, which is meant to be a more rigorous science than physiotherapy, there are all sorts of philosophers of medicine who argue that uncertainty underpins much of medical practice as well. And there's a famous quote from John Lorna, who says uncertainty is the ocean in which we swim in medicine, and he's a British GP. So, and there's the William Osler quotes saying that medicine is a science of uncertainty, and all these things from a couple of 100 years ago, and it really does hold true today in really every scientific field except for fundamental physics.
I don't know if you're familiar with Derek Miles, but he's a friend and a close mentor that has been on the podcast at least once. And his mentor at University of Florida, I may butcher this quote, but I think it's something like always confident, never certain, or always confident, rarely certain, in the sense of, like you were alluding to, there's a path moving forward with yourself as a clinician or with what you're discussing with patients or the plan of care. But there's this inherent uncertainty of a lot of this process. And you can have these two kind of coexisting things, even though they may feel divergent, of still having a plan in the face of uncertainty. Is there, as a young clinician, or maybe even in school, do you think there's a way to develop this being okay with uncertainty? I think, fortunately for myself, what I think really helped me early on was just having mentors that did a great job being very open about that with me and with patients. And sometimes there'd be this, like, a patient would ask a question and there'd be this kind of humble shoulder shrug of, I don't really know the answer, but we still have steps moving forward. So I think for me personally, just seeing it and hearing it was the most beneficial. But do you have any other thoughts or ways that clinicians and new grads can really take this on and adopt that okayness with uncertainty?
I think that's the best. Yeah, I never had that as a new grad. My first boss was a old school physio who, thought he could, feel pain with his hands. um, and that's not to begrudge him or them or ways of practicing. That's the generation. But no, having a mentor for me, it was something that I really wish that I had as a new grad. My mentor was science and publications, which I would take solace in to try and improve my practice. But having a physical person who, is capable of showing empathy and sympathy and can support is far better. But yeah, hearing those words from somebody that you look up to and trust, that, just saying, I don't know, let's try and figure this thing out. Because, I think science is problem solving. And problem solving means that there are problems that are always going to occur. And problems is uncertainty. But we can take steps along that pathway in order to try and diminish or reduce that uncertainty. I don't think we'll ever get to true certainty. So, because I don't think there is such a thing as certain knowledge. I think it's always going to change over time, but I think we can get closer to the truth, perhaps while never getting to the truth. Although we might be able to get to an individual truth, and I think that's important.
Staying on the topic of mentorship, this was another key component of the piece, and it is so helpful, and I don't think anyone would push back on the idea, but do you have strategies or ways for new grads to utilize mentorship or to find mentors? I'm very fortunate that I just developed that and had it throughout the course of being a new grad and continue to have these relationships. But for a student about to graduate or this new clinician, should this be kind of a non-negotiable for them? Like I need, as a student or doing my rotations or in my first clinic, I should find a place where I know that there's going to be a mentor that I can communicate with and lean on and help guide me. Or now with the era of social media, if I'm in this isolated city, I find mentors that I pay online or that there's a group. Like, what ways can we kind of foster mentorship as a new clinician?
Yeah, it's a good question. I grapple with this a lot, and I don't know because I constantly see on social media that everybody offers a mentorship these days, and the cynic in me thinks, is it actually worth it? Is it a grift? Um, yeah, and I'm torn, but I do think that a mentorship in some capacity, it doesn't have to be paid. A mentorship, a relationship with a practitioner that you trust, that perhaps has a little bit more experience. It doesn't have to be much, even, or just has a different way of looking at things, something you can reflect on with or use as a soundboard, is absolutely vital. And I think just being reflective in general of your practice and of your belief systems and constantly challenging and evolving your beliefs is so important. And what better way to do that with somebody who can keep you accountable and keep you honest. Make sure this person, though, is somebody you trust, that is intellectually honest as well, and is wanting to learn from you at the same time as you learning from them. So it's a transactional relationship for both of you. It's not just a one-way authoritative relationship where they're reading from the gospel and you're listening. But if you see a practitioner that you follow on social media and they offer a mentorship and that suits your style of learning, then great. I think you should absolutely go for that. I don't think that's the only way. I think just reaching out and developing a relationship with people on social media can still be done. I definitely have those networks on social media through Instagram and what have you as well, where I come to know people really well, although we don't have any formal relationship, but they sound, I'm not saying people to get into my DMs here and send me 1,000 messages, but if you do have some questions and you're okay with me taking a few days to respond, then I will eventually get back to you. And that's a nice way of sort of having a relationship with someone as well. So I'm not sure if I answered your question with any great certainty there, but I'm still grappling with the question as well on the value of paid mentorships in the guru space of social media. There are other ways to go about it, I think.
Yeah, I think in an ideal world, every new grad had an in-person mentor that they could interact with on an hourly, a daily, a weekly basis. And I know for myself, the first clinic I was at, I had that, and it was unbelievably important and valuable. And at the end of the day, like you said, it's not this top-down mentor mentee, I'm going to teach you everything. It is a lot of times just these shared experiences or shared reflections on practice together. And there's multiple clinicians in the clinic I was at as a new clinician that I would consider mentors, but one in particular where at the end of the day, we would just be kind of drained from patient care, but we would just reflect and talk things through. And sometimes it wasn't even asking questions or trying to learn. It was just like the value of venting and being with someone. And, maybe you don't consider them a mentor. Maybe it's just finding that relationship or that close other clinician to work things through with. But yeah, in person, if people can find that at least with one individual, but hopefully multiple or community, it is super helpful.
Yeah, thoroughly agree. I think just getting the words out to somebody else who can nod or, shake their head or give you some eye contact or a pat on the back or something is a cathartic experience and can really help. There's a quote from Nietzsche that says, "Only good ideas come while walking," but I'm going to change that. I think only good ideas and reflections come from talking to other people and sort of trying to hammer out what you think's happening with somebody. Because if you keep it all bottled up in your mind, I think your mind can start to play tricks on you, and yeah, it's not an accurate representation of what's going on often.
Another big piece that you all discussed is this value of listening as a clinician. And what does that mean? Why is listening valuable? It may seem intuitive, but why should clinicians really adopt this early on and utilize it as a healthcare provider?
Yeah, listening or the therapeutic relationship is key. And so, almost the first point we made in the paper was that no matter what you do, like no matter what intervention you apply, no matter how good your knowledge is at strength and conditioning, corrective exercise, pain science, no matter how good you are at providing a mulligan lateral glide to an elbow, that pales in significance when we compare it to your ability to get along with somebody and to nurture trust and to foster a therapeutic relationship. And I think we see that in the research a lot. A lot of successful outcomes are contingent upon the therapeutic relationship. And so without having that as a necessary precondition, then no matter what you do will probably be unsuccessful, and that person will go somewhere else to seek care. And that's totally valid, and they should do that. Unless we're administering an antibiotic to someone for a particular infection that doesn't really take into account the therapeutic relationship. Even medical doctors are subject to clinical outcomes being dependent on the relationship they establish with their patient. And it's even more so in physiotherapy, where our primary issue that we're dealing with is musculoskeletal pain, which is notoriously tricky and hard to pin down and evades, tight biomedicalism. So listening is a key component of establishing a therapeutic relationship, which I think is the number one influence on a clinical outcome.
Yeah, and we touched on that in our prior episode with you on one of your pieces recently on shoulder pain and patients'
Sure.
perceptions and that therapeutic relationship. Another big one was this, as a clinician in general, but as a new grad, it's really easy and common to just really fixate on this hyper-specific thing. And you all mentioned this idea of a broader scale view of behavior change and self-management strategies. Can you discuss what the value is there and why that is so valuable outside of just being hyper-focused on, maybe the session to session, what that looks like, but then really zooming out and figuring out, how do I try to improve this person's life outside of therapy or by the time rehab is done, what's the value of these kind of behavior change and self-management strategies?
Yeah, it's a good point. So this is one of Jeremy's favorite things to talk about. He's written whole papers with Peter O'Sullivan about sort of changing the way we think about musculoskeletal care, particularly persistent musculoskeletal care, where we're trying to move away from finding and fixing pathology to sort of broad brush lifestyle, behavioral change interventions where sure you can, do a strength test and implement a resistance exercise to change that strength deficit, and that may or may not correspond with improvements in their shoulder pain or knee pain, whatever it may be. But just thinking broadly of the person on a human level, at a societal level, even, are they meeting their weekly exercise requirements, diet? Do we need to think about smoking cessation, alcohol intake, all of these kinds of things? And if you're a new grad and you're not comfortable talking about these things, then that's fine. Refer them on to somebody who is. But often when we look at as someone with persistent pain, it's this complex connected web of variables that often don't involve strength deficits or biomechanics or things that we're trained in. It's everything else, which is a risk factor for developing persistent pain. And so if we're not addressing all of these other things, which is driving that individual's pain, then I think we've just got our head buried in the sand trying to correct a strength impairment that's got nothing to do with this person's complex pain experience. And so that's challenging. I'm not here sort of saying that it's going to be easy, but it comes with the territory. And if you're a physiotherapist, you are a high level professional. You are trusted by the community to provide evidence-based interventions to help their pain. And if we're just sticking our head in the sand and doing things that we're comfortable with, I think we're doing a huge disservice to an individual and the society that we're operating in. So I think, behavioral change, lifestyle interventions, treating the human, not the scan or not the impairment, all of these kind of things that we're being exposed to, hopefully over the last decade or more of research, is super important.
We've already touched on it a little bit, but it's just going to become even more of a challenge or of a benefit, however you see it, or a combination. But touching on your 15 years ago early new grad experience is very different than new grads now with the age of social media. And we, talked about this mentorship conundrum of whether that's ethical or not, or some of this paid mentorship. But as a new grad, it's almost impossible not to go towards social media for some type of learning and education. What are your general thoughts of social media as a new clinician? How do you recommend new grads manage this just overwhelming amount of information that they can take in on a daily basis?
Social media is a part of our lives, and I don't think it's good or bad. It's just something that's there, and we're going to be exposed to, and we're going to use because we're social animals. So yeah, rightly or wrongly, social media has changed physiotherapy, I think, and health science perhaps in general. Maybe not like medicine as much, but certainly like S&C, physiotherapy, chiro, osteo, all of these professions have been heavily influenced by social media, I think. And so what should a new grad do? I think they should use social media. I think they should follow people of all different persuasions, offering all sorts of different advice, and they should come to their own conclusion about the veracity of what these people are, or the accuracy of what these people are proposing. And, hopefully they've been trained sufficiently in science and in critical thinking that if somebody's out there preaching that some sort of cranial sacral therapy can cure somebody's Achilles tendon pain, then that's probably bullshit. Or if somebody's doing some sort of I don't know, they're waving, I don't know what it's called, they're waving their hands over a person via Zoom, and they're getting all these muscle energy things happening, and that person's like healing their trauma, then I think that's a bit crazy as well. But then equally, if there's a guru physiotherapist on social media who's just shouting into the void or into the abyss, and thinks that they're definitively correct in everything that they say, and is not being intellectually honest, and is not open to being wrong, and is acting like a dick on social media, then I hope that student or new grad can say that what that guy, and it's always a guy, what that guy is doing is probably incorrect as well. So we use Hitchens' razor in the paper where assessing the validity of a claim on social media can be helpful, and that says that what can be asserted without evidence can also be dismissed without evidence. And that usually applies to the more fringe claims in social media, MSK space. We also sort of point the finger at people who are overly definitive and not sort of addressing their own biases, and not publicizing the uncertainty around some of their claims as well, which we should all have, as we mentioned a moment ago, with uncertainty. But uncertainty doesn't sell, and uncertainty doesn't go viral. The viral post isn't saying, I'm not sure, it could be this, it could be that. Like, I'm not going to click on that post, so I don't know why anybody else would. So I guess viral things aren't always the most epistemologically accurate as well. So yeah, social media is tricky, Chris, and I'm not going to sit here and say don't use it, because I use it and it's been a huge component of my life, and I really enjoy social media. I don't think it takes away from my life. I think it helps my life. And so I'm not going to be here all high and mighty and say get off social media. I also can't stand people who are on social media saying, oh, social media is not what it used to be, and I'm not getting the likes that I used to get, and blah, 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 blah. Maybe you're just making shit content. So maybe you should look at yourself. Anyway, that's another spiel that I have. But social media is neither here nor there. It's there. You're going to be exposed to it. Use it like everything else judiciously. Use your own faculties of critical thinking to assess the accuracy of a post. Probably don't put your house on one particular post sort of curing anything, or one particular practitioner or online personality that's got it all figured out. None of us do. We're all just doing our best. So spread your bets on a number of different horses in a race, and I think over time you'll start to see the true colors behind a lot of social media personalities coming out, and you'll start to find value in different people's ways of thinking and the stuff they put out there on social media. So again, it's a bit of a tricky answer, Chris. I'm sorry, I don't have a hard and fast answer.
Yeah, I totally agree. I mean, it is tricky, but I think as a new grad myself, would I rather go with or without social media? And it's with. And the amount of relationships I've created that I haven't even met these people in person that are from Instagram or Facebook or these other communities, it's hugely beneficial. And I do think, to your point, the variability, or just the multiple exposures to so many different people, I think that's how it should be done. Of the more you can listen to a variety of different individuals or watch their different videos, you probably are going to hopefully kind of self-select over time people that you start to trust more, or that have some of these traits that make it maybe a little bit more trustworthy to listen to them over time. But yeah, I think hopefully clinicians now, or new grads now, are in a much better spot to really, like, I don't know if the right word's jumpstart, because it's just the nature of this career and there's never like an end to it. It's this evolving like learning process, but hopefully it gets them over the hump. Also, like what the goal of this paper is, but the things that individuals can learn from social media, or the resources that they can gain, or the podcasts, it's so much better than 5, 10, 15 years ago, where none of that was available. It's just awesome how much free and available, phenomenal resources there are on these platforms. So I think it's a net win overall.
Yeah, I totally agree. I think there's this quote by Karl Popper that I like, and it's all all ideas and opinions are valid, and all ideas and opinions should be challenged. And so exposing yourself to as much opinions and ideas as you can, and then applying a critical lens to all of that is really the only way to go. Otherwise, we all get stuck in an echo chamber and we become tribal and we hate each other eventually. So that's my philosophy.
There's this table of recommendations or of resources within this piece, and I'm sure it was a combination of all four of y'all's recommendations. But I want to hear from you, Jared. What are the things within that list, or maybe the things you're like, I wish I could have included that, but we had to narrow it down, that either as a new grad or even more recently that you've taken that you think these are just such great pieces for new grads?
Yeah, so I could have put 1,000 resources on there. We just had to pick a couple each. I put I put a book on there called The Beginning of Infinity by David Deutsch, which I think everybody should read. And he's a physicist from the UK who's an expert in quantum physics and AI. And basically he thinks that all knowledge, all science is problem solving, and that the only way that we can progress knowledge is to continually try and solve problems. And I think it's really helpful because in clinic, we're trying to solve an individual person's problem, and it's okay. The only way that we can try and solve that problem is through trial and error, blah, 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 so on and so forth. And so it's a really cool book. It's quite dense, but I think people will be able to see the relation between what he's saying and clinical practice as well. Another book that I put on there was Calling Bullshit, which is a book about basically propaganda and misinformation and the abuse of statistics by the media and in pop culture. And it's a really, really good book, and it sort of goes into why it uses a couple of great examples in science where, that Andrew Wakefield, the guy who said vaccines were linked to autism, his work was eventually retracted and blah, 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 blah. So even in science, it happens as well. There is a huge abuse of science and statistics in science, especially not just in science, but especially by politicians these days as well. So that's a really good book. Things that a lot of the other resources were by the other guests, so I'll let them, you guys can read that. Some other things that I'd recommend is getting into, start reading philosophy or start listening to philosophy, especially the philosophy of science. We're meant to be a scientific profession, but no one really knows as a physio, because we're not taught it, what science is or what a scientific attitude is. And, science can be fallible as well. It doesn't give us all the answers. When we start to interrogate what science is, we also start to see that a randomized controlled trial doesn't give us all the answers either. It's certainly a meta-analysis of randomized controlled trials does not give us all the answers. When we start to interrogate what science is and how it can be applied in health science, we start to see the value of qualitative research, which is in some circles anti-science. We start to see the value of basic physiological studies and mechanistic studies again. And we start to see how a lot of the things that we've started to hold on a higher pedestal, such as the randomized controlled trial, really doesn't tell us about how we can help an individual in front of us. As we said a moment ago, outcomes are unpredictable, and randomized controlled trials deals in pooled mean averages of a whole cohort, 100 people. And how the hell can we apply that to the individual in front of us who evades the tight selection criteria of that randomized controlled trial? So that's not me taking anything away from the importance of a randomized controlled trial. You're never going to get a bigger supporter of a RCT than myself, but there are limitations to that as well. So I think I don't listen to any physio podcast anymore. I think new grads should. But over the years, as I started to become more comfortable with physio-related content, I listen to yours, obviously. I listen to Greg's as well. He's Greg Lehman's got a good podcast. But other than that, I basically read tangential things related to what we do that I think helps me a hell of a lot more than, how to help someone with knee pain.
That philosophy of science, do you have any go-to starting places for people to start that journey?
Yeah, so I think everybody just has to read Karl Popper basically, and every single book that he has, and there are 90 of them, and he lived until he was 90 years old and was very productive. So for me, he's the goat when it comes to philosophy of science. And yeah, as you can see behind, there's a huge orange book there, and that's Conjectures and Refutations by Karl Popper. But a lot of his books are available on Audible these days, and The Myth of the Framework would be a really good place to start by him, and All Knowledge is Problem Solving as well by him as well. That's a really good place to start. And he speaks in such a beautiful, no nonsense way. He basically hates all other philosophers. So he hates the sort of philosophical, academic, mumbo jumbo kind of talk. He talks in a very comprehensible way. And yeah, that's a really fabulous place to start. And then there's Philosophize This, which is a good podcast as well, and a bunch of really good philosophy podcasts out there too.
Anything else from this piece itself, or just after you wish you had added in? And I know you had said before this, I think within the blog there were like 10 major points, but anything else before we kind of wrap up, Jared, that you want to touch on, of reflections within your own journey as a newer clinician when you were in that place, or for new grads?
Yeah, so I mean, something that we did include in the paper that we haven't touched on, which I think is important, is finding something that you're passionate about in the physiotherapy space. So that there are so many jobs in physiotherapy that isn't musculoskeletal physiotherapy. And there's a pressure in physio, I think, to go into private practice, sports physio, certainly in Australian culture, because sport's so big here, to get into sports physiotherapy. And it's not for everyone. And if you want to be, if you want to work in neurological, physio, aged care, peds, cardiorespiratory, whatever, then just pursue that. Even if you become a musculoskeletal physio, you can even subspecialize. So I've specialized in the shoulder. You can do a bunch of different other things. You can go into management even. You can go, a bunch of my friends who did physio have gone into like orthopedic sales or support, where they work for big pharmaceutical companies, and they go out and talk to orthopedic surgeons about knee replacement prostheses, so on and so forth. So there's a bunch of different areas within this huge physiotherapy profession that may suit your strengths and weaknesses better than others. And you don't have to just, be a shoulder expert or an ACL expert or a SNC guy. There's just so many areas within physio that may not be as sexy and aren't as ubiquitous on social media, where everybody seems to be a white male who loves strength and conditioning, who is fit themselves, who is from a wealthy country. And there's a lot of different other ways of going about physiotherapy, which can help society as well.
Yeah, I noticed that within my own program, where a lot of people entering graduate school as a physical or as a PT student, they had a really good experience with a physio, but a lot of times it was this orthopedic experience or sports experience. Yeah. They were an athlete themselves. They got injured. They assume they're going to go down that path as a clinician. And I saw a lot of students kind of evolve. Either, unfortunately, they had poor orthopedic clinical rotations where they kind of like lost that sense of excitement and they switched paths, or just with the nature of how long schooling is, they realized, and with just new exposure, this world of neuro PT, or specializing in geriatrics or wound care and acute. And that is what's so great about this profession, is you have a lot of options. You can work in a lot of different settings, and even when you graduate, you don't have to be stuck in one spot, and you can traverse the landscape of all the opportunities, which is amazing.
100%. And like, I've changed my practice even over the last 5-10 years. I exclusively just do telehealth now, and I never would have thought I would have done that 5 years before COVID. I wouldn't have thought that. Obviously that's been a lot of people's experience, but it's always going to evolve. In 5 years time, I assume what I'll be doing is vastly different to what I'm doing now. And even how what I'm recommending to patients has changed dramatically over the years. Even with my clinical interest of shoulder pain, that's changing and evolving. I'm evolving my practice. My PhD has been really good at unearthing some of the biases and the dogmatic beliefs that I held as well. And I've had to interrogate that, and I've changed my practice accordingly. So yeah, everything changes at every level over the years, and I think that's okay.
I have two questions. One, if you were not the shoulder physio and you had to be a physio in a whole nother realm outside of orthopedic musculoskeletal medicine, where do you think you would have ended up? And then if you weren't a physio at all, what career do you think you would have found really satisfying and could have seen as another life?
Outside of physio, outside of musculoskeletal physio, that's tough. I really don't enjoy anything else apart from musculoskeletal physio. I could be a full-time researcher. I could be a full-time scientist in that respect, but that would still be researching MSK physio, I think. Maybe epidemiology. But yeah, that's my bias. But if I didn't, so if I couldn't be an MSK physio, I probably wouldn't be a physio. And in that respect, I love writing. I've always been like good at writing. So I think I would be a science writer of some description or a science communicator. I wanted to be a journalist at school. Kind of. I wanted to be a science journalist at school because I was good at science and good at English. So I didn't know how to combine that. But yeah, so that's where I think I would go. I really enjoy writing and making it interesting and not just the boring scientific writing of this is shoulder pain. It affects 10% of the population and these are the tests that we do and our hypothesis is this. I like to bring in a little bit of spice to my writing to make it a little bit more interesting to read, which I hope people appreciate.
Yeah, for sure. Okay, so if you stayed in MSK, but you couldn't be just specialized in the shoulder, what other body region do you think you would have specialized in or been as interested in potentially?
I like the hip. That's another ball and socket joint. So maybe there's something there. Maybe I'm a ball and socket kind of guy. Yeah, I don't. The low back annoys me because everybody loves the low back. I don't love the knee because I just find hinge joints boring as just do like a knee extension to help everything or a squat. Yeah, so I like the hip, I think, as well, and I've got a bit of an interest in gluteal tendinopathy / greater trochanteric pain syndrome because I think there's a big corollary to what we used to call shoulder impingement syndrome there as well, and I'm starting to be a bit dubious on the compression hypothesis of lateral hip pain as well. So yeah, that's something that I'm starting to have a little bit more of an interest in, and I won't be the hip physio ever, but yeah, I think there's a relationship between hip pain and shoulder pain.
All right, Jared. Well, we covered a lot, and I would implore people to actually read the paper. And like you said, there's other resources that these other co-authors have added, and I thought they were all great. And then I'll add some of those other resources you listed and some of maybe Karl Popper's books as well within the show notes. But I appreciate you coming on for a third time. Congrats on pretty much rounding out the PhD and having this kind of open opportunity for all the other things you want to do.
Thanks, Chris. Guys, if you listen to any of Karl Popper's books, tag us on Instagram and we'll share it. And I really want to see it because I think as physios and as health scientists, which is what we are, I think the more we can think broadly and philosophically about things, then I think that it's going to help us and help our patients as well. So yeah, tag us and we'll share it. Hey, Chris.
Yeah, perfect. Thanks again, Jared.
Cheers, mate.